Yes, thank you so much. I am going to keep my comments extremely short so that we can get to the demonstration. But I just wanted to highlight for folks, we are recording this webinar. Something should have popped up for you. We are going to record this and archive it on our website so that those who want a tutorial on how to use the tool will have this recording. I will also draw your attention to the Q&A. So rather than typing your questions into the chat, please use the Q&A. We do have a team that is reviewing those questions so that we can answer them live and verbally after the demonstration. I just think that some of your questions may be answered throughout the demonstration, and so we'll reflect on them afterwards. But as they occur to you, please put them into the Q&A and we will review. So with that, I believe I'm just going to turn it over to our colleague, Marilyn Bartlett, to do a demonstration of the tool by looking at a specific hospital. I will highlight that the hospital that we chose really doesn't have a significance. We were just trying to find one to highlight for this demonstration to capture the new improved data that we have to offer. So I just wanted to add that context. But Marilyn, we're going to turn it to you to share your screen and start moving through the tool.
Well, thank you, Maureen, and thank you all of that have joined us. We appreciate you being on the webinar. What you see on the screen now is the hospital cost tool, how it looks now. You'll see a different screen than if you've been using it before. But again, across the top are the different tabs depending on what you want to explore. I also want to point out, I'm on the overview tab, and here you will see that you could download the hospital level data set. And this is all of the data that you see in the tool. There are about 100 fields for each hospital. And this is the downloadable data set for researchers to work with. You can download the definitions that will explain what each column is, what each field is. These are the 4 different tabs that I showed you above, what each does. Now we've added a section with per state request on the key concepts. There was confusion as far as what hospital operating costs were versus operating expenses. So let me take you through the left-hand side here. What the hospital expenses inclusive of all services include the operating expenses that the hospital reports on their Medicare cost report. But it will also include some adjustments. These are additional expenses. Some examples of these would be expenses coming from the home office, as they may have a particular contract with a vendor and pay for all of the IT expenses, but some of those are appropriate for the hospital. So we'll bring those costs in. We also will bring in physician hospital costs. This is the 24/7 coverage of a physician within the emergency room, within the ICU. So pretty much bringing in expenses that really were needed to operate the hospital, but were paid for by a different party. So we bring those expenses in. We then make 2 different buckets. One is the hospital patient care. This is really all the expenses needed to operate the hospital. In the other bucket are expenses not related to operating care. These are sometimes known as Medicare disallowed expenses. So there will be physician costs if they were included in the expense that are billed under separate methods from the hospital bill. There'll be home office or affiliated expenses that weren't related to patient care. Research is moved out because research revenue is not in hospital operating. Some other things that we move out are teaching hospitals, textbooks, lodging, the salaries for teaching, because that's not operating the hospital. Any sales to non-patients of drugs, equipment, supplies. unallowed advertising, such as sponsoring a sports team. We do also move out services that the hospital sells to other parties. The revenue, if they have a lab and they sell their services to another entity, that revenue will not be in hospital net patient revenue. It's in other revenue, so we move it out. We further then take the hospital operating costs and we lump it into 3 general categories. And you can look on this tab to get a little bit more detail, but it'll be hospital operating labor, hospital operating costs, and then capital related. And these will just be the expense items. So depreciation, insurance, leases. We're now taking labor into 4 categories: direct patient care labor, your nursing, your laboratory, general physician services. That is direct with the patient. There's also management and administrative costs. Then there will be home office and affiliates costs for labor to support the hospital operations. And finally, we have overhead, which is housekeeping, dietary, etc. On the right-hand side, I'm not going to go into the explanation as we've given this before, but this will take you through a little bit on the difference between hospital operating profit and loss versus net income. So I want to start off by explore a state. And at the top, you'll have the instructions of how to use the filters. And I have already populated this one. We're going to be looking at Texas today and comparing it with national. And one little point I want to show you is that if you do choose, and I chose national in Texas, make sure you hit this little button here that says update filter, because that is needed to get the data in. So let's take a look at adjusted patient discharges. This is inpatient, outpatient. And it's interesting to see that Texas is a little bit lower now than the national median. These are medians. You can hover over any point and you will get the detail. For Texas, 362 hospitals. The median is 5,658. Now, it's interesting in Texas, since we're using the median, Texas has a lot of small rural hospitals. So you might see that lower than you would see in other states. We also then break it down. And I wanted to show you, this is what's interesting by bed size. We look at all, but from 0 to 25 bed size in Texas, there's 131 hospitals. 70 hospitals in 251 plus bed size. So it's interesting to see how they compare to national. I also found it interesting in Texas, there are 104 government hospitals. Those are a lot of county hospitals, some of your rural small hospitals, Parkland group, and then a lot of university related hospitals. So you're going to see a kind of a big impact on government compared to the 116 that you see in nonprofit, and for-profit, 142. We then can move to the median net patient revenue per adjusted discharge. And again, you can see that Texas is running pretty much parallel to national, and that's the revenue per discharge. We then compare it by bed size, and we compare it by the hospital ownership. It's always interesting because the 0 for the rural areas, I know that states are very interested in looking at those particular hospitals, and this data will help with that. We look at the operating costs. Now, we just looked at the revenue. Now we're going to look at the operating costs. And again, you'll see expenses going up, but Texas running pretty parallel to the hospital operating costs per adjusted discharge. From the national perspective, the costs here are a little bit lower than national for the 251 hospitals. Now let's get into profitability. The first we look at is hospital operating profit or loss, and this will be net patient revenue less the operating costs. Now, per adjusted discharge, again, I found it interesting that Texas is pretty much paralleling national. It's a large state, so I'm sure it has a big impact. And you'll see that we saw this drop, which we saw consistently in 2020. And this was the operating profit per adjusted discharge. And many times you're going to see this is because the number of discharges was low, going up and coming on back down. We will now take a look at the margin. Did they make a profit? Again, you'll see that compared to national, Texas is right on with a 10% operating profit margin. You can look at each particular year. Now, this is interesting because this has an impact for Texas. Of the 131 hospitals, the median for the critical access hospitals, 0 to 25 bed, is minus 16%. You get up to these larger hospitals, 18%. The 101 to 251 or 250 bed size, 18%. Again, I want to point out governmental hospitals at minus 27. Again, these are the smaller hospitals, the university hospitals, county hospitals. Now, net profit margin is the whole picture. This is what the hospital reports is their net profit, all expenses involved. We saw this continually going up with our last version, and this was a lot of the COVID funding came in. The COVID funding is not included in operating revenue on the Medicare cost report. It's reported as other income. Now we've seen this big decline in 2022. What we're finding is causing that is that COVID funds have gone away. But even more than that, many of the hospitals report investment losses, unrealized or realized. If the stock market made a big drop, which it did in 2022, hospitals are required to record that as an unrealized loss. So you see that drop. Texas still came in at net profit margin median at 8.8% on the 362 hospitals, national at 2.1%. I just caution you as you look through this that you may need to dig a little bit further to understand that impact on net income. And I would look at investment gain or loss on that. Net profit margin, we have 11% on the larger hospitals. But this is interesting, even though we saw the costs, when we get to net profit margin for these critical access hospitals, a lot of times you're going to see government appropriations come in as other income. And I suspect that's what's going on here, is that you're going to see that they're bringing in other income in that realm. So what happens next? We really do focus on the bottom line. So the cost to charge ratio, of course, that's a function of two things. Operating costs is its denominator. Did that go up or down? And then did charges go up and down? And you'll see that that's been coming down steadily. Texas running lower than the national, but you're going to see that it's more a result of charges going up. And we'll look at that when we look at a specific hospital. Cost to charge ratios. Critical access hospitals, the cost to charge ratio is pretty close. They're typically used to billing according to the Medicare rules of 101% of their costs. So you'll see that higher. Oops. And now we get down to commercial break even. This is what would a commercial payer have to pay as a multiple of the Medicare rate for that hospital to cause that hospital to break even so that the expenses cover revenues. And you see, I think it's interesting that Texas consistently followed national, dropping down to below 100% here. But now we get to this point, all hospitals are at 122% commercial break even. Texas is a little bit lower at 110%. This will show it to you by hospital bed size. and by the particular hospital ownership. Now we'll get into labor costs. Labor costs, I find this interesting. Again, Texas is following national. Labor costs as a percent of hospital expenses. We all hear that labor costs have gone up, and they have, but it's also good to look at them in the context of overall expenses. Within Texas, 29%. They were at 28%, pre-COVID. We then take a look by the bed size and geography. Patient care cost per adjusted discharge. This is following right along. And again, you have to look at, was this because costs went up so much, or was it because discharges were down? And you're able to get to that analysis within the hospital cost tool. We look at the number of FTEs per 1,000 adjusted patient discharges. And this is interesting. This is fairly flat. It did go up slightly here. Oh, I'm on national, but in Texas, 35. That's the number of FTEs per 1,000 discharge. And then we get to Texas here, 35. Finally, within a state, because states we're looking at contracted labor. Now, this is Texas. And the first is we look at, of the direct patient care labor cost, how much of it was contracted labor cost? National is coming in at 12%. So 12% of direct patient care labor, the median, 12% of it was contracted labor. The number of FTEs, this is direct patient as a percentage. Nationally, 5.3% of the FTEs were contracted. The pay rate for contracted nationally was $121 per hour. And you have to take all three of these into consideration when you're talking contracted labor. What was the rate? What was the percentage of FTEs that were direct? And what was the percentage of the overall cost? So now we're going to focus on a hospital and review a single hospital. We chose the Texas hospital. We chose St. Joseph Regional Health Center in Bryan. It's interesting because this hospital was owned by Catholic Health Initiatives, CHI. And in 2019, it combined with Dignity Health to form Common Spirit. So it's an interesting one to look at with the change in ownership. So the first chart here will tell us the net patient revenue per adjusted discharge and the cost. This spread here will be your operating profit. We've got two new charts that I wanted to show you. I'm going to start with, if I can. Sorry about that. We'll start here. What we're taking a look at is we've grouped the costs like you saw in the overview chart. The pink is direct patient care labor. The yellow is the labor other than direct, so your overhead management, home office. Green are your capital related costs. Other hospital operating costs, that's your supplies, your drugs, the different things to keep the hospital going. But this purple category are the operating expenses not related to patient care. And it's interesting to look at the trend. Now, what I found for this hospital when I did a deep dive, what has been disallowed here is $21 million for home office and related party allocations. Refunds and rebates received. We take it in and we offset the expense. Rental expenses were $600,000. Reimbursed expenses for they sold their services to someone else. They had the full expense of the lab on their books, but they received $1.7 million in reimbursements. And then this was interesting. They do report that they reduced expenses or moved operating expenses here, $415,000 for their cost on 340B drugs, not their revenue, but their cost. We then take it down to look at the line charts to see the trend. So these are the same issues. As you can see, the percentages stayed fairly flat on some of these. We did see the increase here in direct patient care labor is at 26%. In 2019, it was 24%, but it has gone up. So again, looking at the trend, you can see the purple line, which is the additional expenses not attributed to patient care, that's been increasing. We look at operating profit for this hospital per adjusted discharge. The operating profit margin, they're coming in at 13%, up a little bit. Oops. Charity care as a percentage of net patient revenue. We've seen this decline in the net charity care. A lot of that could have happened because of Medicaid eligibility with the pandemic. Also, some of the uninsured funding that came from the federal government. We've seen that uninsured and bad debt cost is running around 2% of net patient revenue. So we want to know the payer metrics. We take a look at the payer mix. Now, this is the volume of services, basically the charge master for rates for the services. So on the payer mix, we see that commercial, 42% of their payer mix is commercial. We have seen over time that the blue line for Medicare and the purple line for Medicare Advantage seem to be inversely related. One comes up when the other goes down. 8% for charity care and uninsured. And then Medicaid, they're at 9%. So that's the payer mix. The next thing we take a look at is, okay, what was the profit or margin by these? And I found this really interesting because they were all about the same. Texas has disparate funds that may be contributing to the Medicaid margin, but I found it really interesting. Usually we see that commercial higher, but now we mix the two together. We saw 42% of the payer mix was commercial. While their profit margin may be lower, they're still coming out the highest here. So this is a mix to give you the weighting. Bottom line, this is what we encourage users to use. We saw the cost to charge ratio coming down. And I made the comment, is it because costs have gone up or is it because charges have gone up? And we see this continuously. We see that it's charges that have been going up to bring that cost to charge ratio down. So when you're working with insurance contracts, are you paying a discount off the charge master? Are you paying cost plus? It's kind of good to keep this in mind. Commercial break even for this hospital, they're at 132%. And you can follow this over time. Interesting, you can look at when they were under CHI, this gradual going up. You can see there are probably some financing changes, counting changes. Now we get to labor costs. Oops. We're now splitting the labor costs into those 4 buckets. On the left, we see what the total labor costs were. Direct patient care, definitely the highest on that. You'll see the other 3 categories of total costs are kind of in the same realm. But then we get over to the rate per FTE. And home office and affiliates, they're right here. You see the total value was 9.9 million, but the hourly or the total salary per FTE is around 152,000, dropping down to direct patient care at 104, management administration 88, and then overhead. It's interesting because you can see some of the philosophy here that they may be dropping a little bit here in along the way. This hospital doesn't do it, but you'll see some where you'll see that management responsibility is going to home office. You'll see that increase while the other one decreases. Direct patient care labor costs, they went up per adjusted discharge. In this particular case, their discharges went up too, so that tells you their costs were an increasing factor. Direct pay, the number of FTEs per 1,000 discharge, dropping, but still staying fairly flat for the number of staffing. Now, this will show you the amount of direct patient care staffing. And we like this chart because it clearly shows you how much is direct. You can hover and get the dollar figure versus how much, contracted versus how much was hospital staff. Now, as you see this increasing, which I think was important, if you remember that other chart we looked at in the 2018-19 frame, it was the same percentage of total costs, overall costs as it is now. So this tells you the hospital costs are definitely going up. We then compare it for this particular hospital. I like this chart because it can help center the discussion on the impact of contracted labor. And what you see here on the top is the direct patient care FTEs. So this is the hospital staff. They're at 1,273 FTEs. They're at 31 FTEs for contracted. So over here, that rate may be 190 per hour, but you've also got to consider the mix of contracted versus the hospital staff. Okay, I'm going to jump quickly before we run out of time back over to compare across hospitals. What I wanted to look at was all of the common spirit hospitals in Texas to see if there was what was going on. So this will show you the adjusted patient discharges. So they have some small hospitals too, as you can see. The net patient revenue per adjusted discharge. Now we compare this system nationally. So you can look at each state and you can see that this system really has the higher net patient revenue per adjusted discharge in California and Minnesota. 4 hospitals in Minnesota, you see this 27. Texas is hovering right in here in the middle. We look at the net patient revenue here by hospital. We just showed it to you by state. Now the median, now we're looking at by hospital. And then down here, we can compare the number of hospitals. There's 139 nationally, 14 in Texas, and this is the median. So that's a good, easy way to compare. Now we get into the hospital operating cost per adjusted discharge, and we can see where Texas is within the realm. We can see each hospital and hover over it. We can jump down here. We can see their costs are lower. 12,470 for the 14 hospitals compared to this health system median nationally. Profitability. And this is interesting. In looking at common spirit for this particular year, there's one hospital that's really looking at this, at the operating profit here coming down compared to this one that is higher, but this is a 0 to 25 bed. The profit margin, again, compare it nationally. This is the net profit margin. Now, this was the hospital I wondered about. It was a 36% loss. It is a small hospital that probably you'd want to look into. This St. Joseph's Regional Hospital, this is this is our hospital. And I wanted to point it out to you here, the loss on that. Here they are nationally compared to this. And again, you can put in different years. I put in 2022. Net charity cost as a percentage of net patient revenue. You can see Texas is running higher than the national for common spirit. Uninsured and bad debt, Texas is running slightly higher than the national. Cost to charge ratio, we talked about that with a specific hospital. Texas is coming in at 22%. This is you saw the graph with the cost to charge. You can compare that. It's right on target, 22%, the median in Texas compared to national. Now we get into break even, what a commercial payer would need to pay the hospital in order for the hospital to break even. And this is the 100% line. And these are the rates. And the last chart, we compare, this is the 2022 break-even amount in green. The yellow is the RAND 4.0 price, which is a blend of they use the claims from 2018, 2019, and 2020. So in all these cases, this is what RAND is saying from their claims data, that this hospital is being paid as a multiple of Medicare for inpatient, outpatient. And this is what the hospital break-even point would be for the hospital in that year. Just skipped some, didn't I? Here we get into, labor costs. We are looking at this particular one, direct labor costs as a percent of hospital expenses. And they're running in, this will be 41%, clear on down to here at the 25. Again, you can compare common spirit. We look at direct patient care costs per adjusted discharge. This one was high. I looked at this particular hospital. It's St. Luke's Health Baylor Medical Center. And they ended up that year with fairly high costs. But you could go back into the View Hospital and look that up to get a little more information why. Okay, direct FTEs per 1,000 discharge. They're right on their national median for the system. The hourly rates for direct patient care hourly rate. You can see that going up over time, which you would expect. Texas coming in a little bit lower than this, and that could be their heavy presence in California where wages might be higher. Okay. The very last tab is Explore by Health System, and you can put in any year in any system. I went ahead and used Common Spirit in this point because this first one, I think it shows you the volume of business that they have in the different states. And we work with most of these states directly. So this is a system that we are familiar with. Texas is actually the fourth. With 14 hospitals, there's 155,000 adjusted discharges compared to California with 27 hospitals, 428,000. Most all their hospitals are not for profit. And as you would expect, most of the adjusted discharges, the highest volume from the largest hospitals. We then look at the median operating profit per adjusted discharge. And this one's interesting to me because it's California that's the highest for the profit. California comes down a little bit. We have Texas over here with their median. Again, the median is from all those hospitals you saw in the last tab that showed they range from critical access clear on up to some of the larger hospital systems. The last thing we look at now, this is total. This is the first time we've shown you something that wasn't a median. We are adding what is the total operating profit. California, the fact they have so many discharges, they may have the lower profit margin, but that volume makes up for 1.5 billion in operating profit. We get to Texas, and we actually have a loss. So I wondered, where'd that loss come from? I've got to look at that. And it did come from the hospital that we noted that is with the Baylor, that had come from the Baylor system. And that particular hospital had a loss of 60 million recorded that year. Now you can go back up and you could pick a different year. You could go back to 2021, 2022, and that will give you more insight to how a hospital system is working on that. Now, one of the things that's interesting when you did go through the view of hospital here, I wanted to show you on this that it will show you that Common Spirit Health is the health system in 2020, but in 2019, the health system is Catholic Health Initiatives. So we have updated the system with the compendium information that will put this hospital in the system it was in that particular year. Well, I've kind of rushed through this. I wanted to leave plenty of time for questions. And I thank you. I hope you look at this and give us some feedback. Again, hopefully the labor costs will help out as you have discussions as states have discussions with hospitals, employers with their TPAs or with their hospitals if they're direct contracting, to get a full picture of what is the contract labor picture. And then also look at how expenses are allocated. That can give you a little bit more picture too for where the hospital's at. So Maureen, I'm going to go off sound and stop sharing, although I may need to look something up.
That's okay. You stay unmuted because we do have some questions that came in, Marilyn. So I'm grouping some of them for us to go through in a sort of hopefully efficient manner. But let's start with a baseline question that I think is really quick and easy to answer, and you just led into it. What is the data source used to determine hospital affiliations with health systems?
Oh, thank you. Yes, it's the compendium, I always get this wrong, AHRQ compendium, and Mathematica does that work for us. The compendium is updated from a federal government source, and that is the system we use.
And I'll just add in a quick editorial comment. We have gotten feedback from individuals about hospitals changing health systems, which we know happens. But because we do use a standard national data source and we do try to update that on a more routine basis, we recognize that there may be a few months that you are all using the data that it may have an old system noted. We really are trying to keep it updated. And so as the compendium gets updated, we update the tool with that information. Okay, so another just data source question, Marilyn. Could you talk a little bit, and I know this was said at the top of the hour, but talk a little bit about the data sets that we use. So one of the questions was, are all of the visuals that are shown in the tool based on a single data set with all hospitals? How are hospitals selected? So if you could talk a little bit about the Medicare Cost Reports and then note how we determine which hospitals are in the tool and which are not in the tool.
Sure. Thank you, Maureen. The source of all of the data is the Medicare Cost Report, which is filed by the hospital. Any hospital that receives Medicare funding of any type are required to file an annual Medicare cost report following specific stated standards. Now, the only items in there that don't come from that are the data source for our hospital system, the compendium, and then also the RAND 4.0 numbers that you saw. In the downloadable data set, we have the RAND 3.0 numbers, but the rest come from the Medicare cost report. The Medicare cost report that we are using are for any hospitals that are classified as critical access hospitals or that are classified as acute care short-term hospitals. So we are not including the psych hospitals, some of the specialty hospitals. It will include the teaching hospitals because they are classified by Medicare as short-term acute care. So long-term, those types are not included. The data all comes from the Medicare cost reports. All the data is stored in the CMS database, HCRS, and Rice University is able to access the different fields within HCRS to compute the different metrics or report the different numbers.
That's perfect. Thank you. I'm going to move to some questions we got about commercial break even. And I will just note that we do have an explainer document on commercial break even that is on NASHP's website. Perhaps we can put that in the chat. One of my colleagues could put in the chat the website where on NASHP's page, you can get to the hospital cost tool and you can get to some other resources. But Marilyn, could you talk a little bit about how break even is calculated?
Sure. What break even is we take a look at what the commercial payer would have to pay in dollars and cents to cover their own patient costs, to cover any shortfall that came from a government program. So was there a shortfall on Medicare, Medicaid, to cover charity care, and to cover uninsured, to cover any, we also include all the the Medicare disallowed costs. So there are costs that Medicare disallows, but we go ahead and bring those back in. So really it is what would you have to pay as a multiple of Medicare to cover those different losses or expenses the hospital has from different sources and cover your own patient care. And then we express it as a multiple of Medicare for that hospital, because every hospital has a different multiple of Medicare, as the Medicare rates are based on numerous things, the hospital geography, location, risk, etc. And so it's unique to that hospital. Reen, do you want to add anything to that?
The only thing I would also add, and it's pointing folks to yet another resource, I don't want to make it complicated, but if folks are interested, you can go to our hospital cost calculator that we also have linked, which is literally the Excel document that includes information as you get into the specific metrics. It notes where on which schedule from the Medicare cost report, which line is being used. And you could even do this on your own. You could pull data from a Medicare cost report using the instructions and the guidance by the hospital cost calculator to help you literally walk you through where all of this information is taken from. We do not post our specific formulas, but we do walk you through exactly how to get the results that we got by using Medicare cost reports themselves. Marilyn, anything else to add to that piece?
No, I think it's good. I like the Medicare cost report. The instructions are pretty clear, but that how you are to report. They are gap-based, and there is an attestation that the hospital's senior leadership signs that attest that the information is correct. Now, sometimes there'll be data missing. Sometimes the hospital won't quite report the information in the field that it should report it in. So we've accommodated for that in the downloadable data set. You will see a period in a cell if the data was missing, and then you will see an NNA in the calculated formulas if a missing item caused a problem. For instance, what if they recorded 0 for discharges? You can't divide by zeros. And an explainer on what that is included in the downloadable data set.
And I'll just point out the downloadable data set as well as definitions for all of the metrics and all of the different language and terms used within the tool are right there on the tool's homepage, and they are downloadable so that folks can use them. We're getting a few questions from folks that are asking why a hospital's commercial break even might actually be below 100% of that hospital's Medicare rate. Could you talk about why that happens?
Yes, the most common is that they're making a good profit on Medicare. So if they're making a nice profit on Medicare and Medicare is paying them 120% of the costs, then to break even, we convert that. It's not going to be exactly 80% because we're multiplying and dividing by different numbers, but let's just, for a simple example, say it's 120%. Then you're probably going to be paying 80%. Because that would get you to break even point. So that's one thing, is that they're making a lot of profit on that. What we also see in some areas is Medicaid maybe making a profit depending on the funding sources that are coming through from the federal government. I know within Montana, the hospitals show a profit on Medicaid because of how the UPL payments are handled. So that will fluctuate, also showing that there's actually credit coming through from those government programs.
And I'll just elaborate by sharing, we at NASHP recognize that Medicaid's reimbursement for specific services may be below the commercial rate or below Medicare's rate, but we are able to take the data from hospitals on their public payers, including Medicaid, that considers their supplemental payments. So those payments that go to the hospitals that are supplementing the individual reimbursement for services. So what Marilyn is noting is the upper payment limit that Montana Medicaid pays. We also can include disproportionate share payments. We can include additional funds that come to hospitals through different provider taxes aligned with Medicaid. And so it really does look at the full Medicaid payment. So just to add that, Marilyn, anything else you want to? Okay.
Thank you. I'm glad you clarified that. Thank you.
Okay, so I also got a question about why hospitals? Why focus on hospitals? And I don't mind starting this answer, and then Marilyn, you can chime in. Recognizing that health systems are responsible for other care, long-term care, behavioral health care, primary care, and on. This really was driven, the creation of this tool really was driven by what state officials were asking us for. They really asked us, how do we know what it costs hospitals to cover different patient services? How can we understand, as we're looking to potentially make changes to reimbursements to hospitals, how can we ensure that we're not suggesting making reductions that would harm the hospital in a way that would force them to close, force them to reduce service lines. State officials really did want to understand what the cost was to provide patient service specifically by hospitals. And so we sought out to provide that response. I will also share, we know that this is just one data source, and I'll let you know, Marilyn, why I'm making that pitch right now. There are other data sources that answer other questions. And so this one really does just focus on a myriad of hospital expenses, profits. We do try to make the connection to overall systems, but it really, why hospitals is because that's what folks asked us to help them figure out. But Marilyn, if somebody on the line did want to understand some of those other costs for a health system, where should they go?
Certainly. I would just say that we use the audited financial statements quite a bit, but realize those are for the system, and a system may own for-profit entities, may own unrelated insurance companies, may own provider businesses. So that will give you the overall picture. I like the audited financial statements quite a bit to understand the whole financial structure, to understand the cash reserves, to understand the property, the building, etc. We also use the 990s. The 990s are a good source. You have to be a little cautious on those to make sure you understand the entity. Most of them are filed by the tax ID number that may include different clinics and different types of ownings under that tax ID number, or they can also file a group 990 that will include numerous facilities with different tax ID numbers. They will be listed on the schedule there, but that gives you different information. It will give you more on compensation, community benefit, different types of information. You just have to be really cautious of what the entities are. We use the Medicare Cost Report because it is hospital specific. It's the only one that is out there that is hospital specific. So that's why we're using them. There are other data sources, but those are the three main ones that we use. And to answer the question, why hospitals? It's definitely the largest component of the 4.6 trillion that is spent on healthcare in the United States. So we do have our group, our whole work group that works on pharmacy, drug, pharmacy spend. We get into a little bit of that here with a pharmacy part of what drugs are dispensed within the hospital setting, medical RX. So that's kind of why we did it and why we went to the Medicare Cost Report, to be able to get to that hospital specific.
Yeah, now I do see some other questions coming into the chat. I'm aware of the time, so I am going to start closing us out. We are capturing these questions. I'll just share so that we can update our question and answers that are online. And that leads me to, again, the point that we're trying to make, that we do have a number of resources online to help people understand this resource. We have the downloadable data, we have definitions, we have the hospital cost calculator, that really will help people navigate and understand where all of this is coming from. Somebody asked, and I answered directly, if they can download the actual visuals, so they could use the visuals from the tool. You could screenshot the visuals, and if you wanted to recreate them yourself, you can use the downloadable data set to do so. And then I will also just highlight that we do have explainers. We have one on break even that we released along with the original release of the hospital cost tool. And we are pulling together other explainers on profit, operating profit, net profit, things of that nature. So more to come. But I just want to thank everyone for signing on, listening to this. I know it can be intense and there's a lot of information to digest. I also just want to give a huge thank you to Marilyn Bartlett, who really, it is her idea to pull this all together. She does look at things from an accounting lens, which is so helpful because it really is the dollars and cents so that people can take a look at this very objectively. So with that, I just thank everyone, and we look forward to working with you all in the coming months. Thanks, everyone.